Dear Facebook Pure Urology viewers, good evening, one and all. Today our topic is renal transplantation surgical steps by Dr. Abhijit Patel. Already Abhijit, I think, has done one talk in this forum. So I will directly go for a introduction of Dr. Abhijit. So today our session is on renal transplant, artery and vein, how to do the anastomosis, unedited video. Dr. Patel is MS MCS. He is a urology and transplant surgeon from MPUH Nadiad. His expertise in kidney transplantation and vascular reconstructive surgery. He is recipient of several prestigious scholarships and gold medalist in MCH Urology and Andrology. Recipient of MIUC International Travel Fellowship from USA at UCCon 2020. He has published many scientific papers in national and international conferences and journals. Reviewer for Journal of Minimal Access Surgery. Has also devised a novel cost-effective laparoscopic for resident which was selected by Santo and Bantu at SIU Athens 2019. So definitely he is focusing on kidney transplantation. That's what I came to know recently. Hi, Dr. Abhijit Patel. Good evening.
Hello, sir. How are you, sir?
How are you? Thank you for accepting the invitation. I will ask quick questions and before we hand over the program. What was in your mind when you are doing MCH urology? In which areas do you have any? See, when I was joining, I was interested in transplant. I didn't know much about endourology, but after joining and after private practice, much of my focus has gone into the endourology because transplant from beginning in private practice was scope was less in big city. So I focused on endourology. So when at the beginning of the urology, everybody will have certain dreams. Do you have idea about the transplant and endourology at the beginning only, or over a period of time you developed?
So, to give it an idea, sir, I was quite happy to tell you that I had exposure to all subspecialties of urology during my residency at Nair Hospital under the chairmanship of Dr. Hemant Patak sir. So the one surgery that fascinated quite a lot was a vascular surgery. At that point of time, we were involved in AV fistulas.
Okay.
And we also had an access to the renal transplant that used to happen at Nair Hospital, which was live related, where the donor used to be done by lap donor nephrectomy and the recipient obviously by open approach. And there was also a cadaveric program that was running by. The one thing that I liked about transplant was my fascination towards the vascular anastomosis and the goodwill that you develop by giving a person who has been suffered for quite a long time, and once you give him off the dialysis, that happiness that the patient has and you have is beyond any expression, sir. So that is one thing that attracted me towards the kidney transplant, sir. And obviously by leaps and bounds that is the kidney transplant numbers are going to exponentially increase in India.
Yeah, recently transplant is done everywhere, more commonly by the juniors also, and the nephrology teams are aggressive. And I am seeing a lot of transplant being done by the youngsters.
So, sir, to give you a statistics, India requires 1.5 lakh transplants a year. India is currently doing 15,000 transplants a year.
Oh my God! Oh my God! Is it?
Yes, sir. This is the official number by ISOT.
Then we also will focus on transplant slowly. We do monthly one transplant. That is our statistics, but long way to go. Do you think Abhijit, nephrologist has a major role is mobilizing the case and putting it for the transplant before we take up as a challenging case?
Yes. So the thing is that a patient initially comes to a nephrologist as a CKD patient. He lands up in dialysis, and once he is on maintenance dialysis, the nephrologist or the physician where the patient is being treated has to refer the patient to a nephrologist where there should be a proper counseling, and also there's an important role of MSW, the social worker department, where they counsel a patient that it's a very painstaking step, sir. So for thrice a week dialysis, the patient and one relative is completely engaged. and thrice a week is just like your life is gone for complete dialysis. So
Yeah.
explaining the patient, and so the benefit of India is that India is a very emotional country. So, if once you start the discussion with the patient that once you are done with transplant of the dialysis, there'll be a good life for you ahead. And especially all the young people that have this CKD problem, there's a lot of productive life. And once they are done with their transplants, they have a very good productive life. They can extend their family, they can do their daily activities. And that is how the patient gets convinced. And obviously, the donors, as we have seen in the last 4,000 transplant, the most common donor, first being mother and second being wife. These people are always with you to donate kidneys. So once you start a discussion and also it is our responsibility also. Suppose you as a urologist have a bilateral stone, obstructive stone with a creatinine of 5. And once you
Yeah.
treat it, it's our moral responsibility to refer the patient to nephrologist so that he remains under care. And if need be, he'll be on transplant after some time.
Yes.
There are even a subset of patients who actually know that they are CKD5 and they would like to undergo preemptive transplant before they initiate any dialysis.
And what about the ABO incompatibility? We are proceeding with incompatible donors, and still success is there. Do you have
Yes.
any experience in Nadiad?
Yes, sir. So we have started our ABO Incompatible program way back in 2014, and we are 124 plus numbers now with ABO Incompatible transplant. And we regularly do, and that is not a criteria for us for choosing a donor. So we regularly do an ABO Incompatible transplant, just the patient being knowing that the cost and the heavy immunosuppression that would be required. Because the patient preoperatively will require plasmapheresis, rituximab, and there's all the cost involved in it. But since there is need of donors in India, we just cannot reject a donor just on blood group.
What about the nephrologist in Nadiad and MPH? I heard sir is very famous. Can you tell briefly about your HOD nephrology, who is yeah, a lot of people doesn't know about the nephrology department of Nadiad because independently you are academically active units. May I
So,
know little about your chief?
so to start off with, sir, the hospital started in 1978. The hospital to have a name, so Nadia didn't have a name. So for the hospital to have a name, the hospital at that point of time was inaugurated by the President of India. That garnered quite a discussion about it. But still, after 1 or 2 years, the name just waved off. So the thing that could just attract the name was a kidney transplant. So in 1980, the first transplant took place at Nadiad, where there was not even a blood bank at Nadiad. And that was done under the able leadership of Dr. M.R. Desai sir and Dr. M.M. Rajapurkar sir. So
Hmm.
Rajapurkar sir was the backbone of the nephrology at MPH. So he was the one person we actually devised the dialysis machine. Then there was no one in Nadiad to look for renal biopsy. So he started, in fact, he started the fistula and then the urologist took over the fistula. So
Mm-hmm.
he used to biopsy, he used to understand himself the renal pathology of the disease, and that is how he garnered. Then the thing came up that what if intervention is required? So we have a state-of-art cath lab at our hospital, which the nephrologists handle, and Dr. Rajapurkar sir do all the interventional nephrology at our hospital. So the backbone, like MR Desai sir, is MM Rajapurkar sir, followed by the chairman of nephrology department, who is Dr. Shishir Gangsar. He's trained from CMC Vellore, and he's now the backbone of the nephrology team at our hospital. Followed by we have consultants like Dr. Umapati Hegde, Dr. Abhijit Kunnur, and Dr. Hardik Patel.
Okay, very nice. So five nephrologists are there.
Yeah, and we have a 50 dialysis center.
Rajpur, what is his name? HOD name?
Rajapurkar.
Rajapur. Rajapur sir is a well-known person. When I ask my nephrologists, they know very well about them. But as a urology unit, in the common conferences, we never had interaction with nephrologists. Except one
Yes.
time I attended for the access for the renal replacement therapy other than transplant. That time I heard about him.
Yes. Yes.
Great that he has dedicated entire his career and now also is giving rendering his services. With this
Yes, sir.
introduction, we will hand over the program. I thank once again, and you please concentrate on surgical technique and don't do not be in hurry. This is only one
Yes,
to
sir.
one session. Whether 100 people see, 200 people see, doesn't matter, but the video link will be there forever. After
Yes,
that,
sir.
usually 1,000 audience are getting benefited in 24 to 48 hours.
I
So
see.
I will be intervening with my basic knowledge, please. Thank you very much.
Well, thank you, sir. I would, is my screen visible, sir?
Yes, yes, very nice.
Okay, so I would like to take this an opportunity to thank Dr. Chandraman Bhatti sir and the Pure Urology Group, which has now increased exponentially to include 8,000 plus urologists, and probably it is the largest urological group in world. So I am quite fortunate to tell that this is my third opportunity and association with Pure Urology. And now my current talk is based on renal transplant. It is focused on arterial venous anastomosis, and it's sort of semi-edited video just because it is not taken by professional camera. So we have just slightly edited it. So there's nothing to disclose except that there are many ways to skin a cat. So as they are surgeons, there are different ways of achieving same thing. And at this point of time, I would like time to acknowledge my gurus, Dr. Sabnis sir and from Desai sir, from whom I learned the art of transplant. It's actually not a surgery, it's an art. You have to develop the interest in transplant and develop the art of transplant.
Very few know that Sabnis sir does transplant very well, and he is established in patient in places like Bihar. Also, they were mentioning he used to come and start first transplant
Yes,
uh,
sir.
because he is known for peace, and much of the people doesn't know youngsters. But he is a good transplant. Mahesh Desai sir to high hai,
Right.
but Sabnis sir also does vascular anastomosis. I heard.
I would like to share one thing about Sabnis sir, which I don't know how many people know, but he is an officially trained transplant surgeon from Liverpool, London, UK.
Oh, is it? Oh my
Yes.
God, great.
Yes, yes, yes. He has done a surgical residency over there.
Oh my God, is it? Very
Yes,
nice.
sir.
He is so simple. He doesn't talk anything about those things. Great. When Muthu was there, I thought he was the unit head and he was doing most of the work other than Mahesh Desai sir. But I didn't know that background. Sabdi sir also does a lot of transplant work, and
Yes,
now
sir.
you are showing keen interest in that. Yes,
Yes,
please
sir.
proceed. Thank
So
you.
going ahead with the talk, what are the principles of vascular anastomosis? There is not a way of doing anastomosis. There are certain principles of vascular anastomosis that we need to honor and do the anastomosis whichever way we would like to do. So the first principle is there should be adequate exposure of the vessels so that you have a good proximal and distal control of vessels. In need be whether, see, we need to understand that these are the vascular and these are the great vessels that we are handling. If there is slightest of leak in the anastomosis, it's going to be disastrous. So we need to have an adequate exposure of the vessel so that we have a good proximal distal control, and if need be, we can take extra sutures. So there should be a gentle and careful handling of the tissues. This is a reconstructive work. This is not a destructive work. In destructive work, you can just hold off with the artery and you can just clamp it. That will not happen. Right from the starting of donor nephrectomy, the artery should be handled minimally so that the artery doesn't go into spasm. And as in recipient also, there should be gently handling of the tissues. You give respect to the tissues will give respect to you. So there should be appropriate diameter of anastomosis in both the vessels that you're suturing. This is very important. Your suture should pass through all the layers of vessels, and it should be a intima to intima or endothelium to endothelium approximation. If you anastomose endothelium to serosa, it will not work, and it will in fact lead to intimal dissection, and your two lumen will get obliterated, which will lead to graft loss. One thing about transplant is beyond vascular anastomosis, it's I think a surgery in our urological government of the highest responsibility, because there are two lives which are involved in transplant. One person has voluntarily come ahead to give a kidney, and one person is dependent on that kidney for his life to change. Then you should have a monofilament non-absorbable sutures. This is most of the time a proline in open surgeries, and now as the robotic surgery is coming up in transplant, this proline is being replaced by Gore-Tex suture, which is again a monofilament non-absorbable suture. And as I said, it should be a full thickness sutures. You have to take small bites. You should get big chunks of tissue. And your sutures, as you can see in my subsequent videos, they should be evenly distributed. There should be no tension at anastomosis at the suture line or knots. I mind you, these are small suture material 6070. Use a loop for that. And these are not 10 suture material where you tighten it very strongly. They will break off. And once you're done with the anastomosis completely, and at the end point, if you just your sutures breaks off, you have to do the complete job again. And mind you, this is you are in a cold ischemia time. Time is against you in this surgery. So there are some basic instruments or your armamentarium that you require for vascular anastomosis. First and most important thing is to have a vascular loop. My loop is a 3.5x loop, and you should require some clamps, traumatic clamps. This is for extra iliac artery. This is for intra iliac artery. For handling of the vessel, there are either a traumatic vascular forceps or this is a traumatic vascular ring forceps. You require a suture material which is proline. So at our institutional preference, it is 60 proline and a 13 needle for vein and 9.3 for a artery. And it is an inferior epigastric artery, we would be doing it by 70 proline, 9.3 needle. Now, internal iliac artery anastomosis versus external iliac artery. This is an unending debate in the subspecialty of transplant. It is a purely surgeon preference. We at the institute, as an institutional policy, do lots of internal iliac artery. One, the thought being that it gives a proper hemodynamics to the graft, and also the limb is not at your stake. Second, and the third thing is that when you, if need be, if there's a graft nephrectomy, you just try to ligate over here and your limb is not at stake. And fourth thing is that if anything has to be done in the post-op period, if you want to do a re-anastomosis, you can obviously disconnect it and again use the extra iliac artery. These are thought of using an intra-iliac artery, but nonetheless, it is just a preference. But we do have reservations for extra iliac artery, and if it's an elderly male with diabetic hypertension where this intra-iliac artery tends to be atherosclerosis or plaqued heavily, then we do not, either if there's a plaque in intra-iliac artery in this artery or at the origin of intra-iliac artery, we do not clamp it, we do not touch it, and we directly go for an extra iliac artery. Now, these are sort of semi-edited videos where I, in my talk as an outline, will show you videos first for vein, and the vein is first is a left donor vein where the length is not of issue. Second video would be a right renal vein where the length of the vein is an issue and how to tackle it, and followed by arterial anastomosis. It would be an internal iliac artery, external iliac artery, and an inferior epigastric artery. This would be an outline of my talk.
Very nice.
So coming on to the first scenario where there's a left donor and you have to do a vein anastomosis. So this is how, this is the internal iliac artery dissected. This is your extra iliac vein which is dissected. This is a sling. Now the point to be noted is this is the vascular clamp. It's a sort of Satinsky vascular clamp. And where do you apply it? So the point where you think your venotomy would come, that I would sling at the highest point and would apply it equally on the both sides. See, where do I plan is because I need to know where my artery would lie, and that is accordingly I plan my venotomy with the forceps. It is my experience that the width, see, as you see the width of the forceps, that is generally the width of donor renal vein of the left side is. So there are two ways of doing a venotomy. The venotomy has both walls of the venotomy should be widely apart. So either you can use a 11 number knife and then you can cut the edges, or you can take a pot scissor that I have taken and cut it. Once you cut it, there would be some amount of blood which you just flush out with cold saline, heparinized saline. And then once you know how big is your renal vein, you can just cut it off. The width of this can be dependent or can be judged by two ways. If you are early in your career, what you can do is you can start off by your own way of determining a size, and then you can slightly increase it. Or you can, during a bench surgery, you can measure the two ends of the vein, how broad are they based on this forceps, and then you can take. So this is my first suture out to in. This is a 60 proline 13 needle. And now this is my graft. The most important thing in this is my ureter should be in the caudal side. It should not be on the cranial side. Then it would lead in a topsy-turvy kidney. this is my where my adrenal vein was. I need to know, in this case, we had cut the adrenal vein, that is why you cannot see. You need to know whether there is any twist at the hilum. You cannot anastomose a vein which is twisted. So the first point that I noticed was whether there was a twist in the renal vein at the hilum. As you can see, this is my caudalmost point from where I have come again into out. As you can see, this is the proper width of the vein. Now, as you see that this length of the venotomy is not sufficient. So at this point of time, what I would do is I would take a pot scissor and would try to increase this depending upon the length of the width of the renal vein. Now the suture that has, now this is the suture where I will try to ask an assistant to stretch it, and accordingly I'll come to know the cranial point of this vein, where my assistant is resting my renal vein on his index finger. With two forceps, I would like to open the point. This would be a point where your adrenal vein is located. And as you see, as the assistant stretches the cranial, caudalmost point, you find the most cranial point, so that your vein is properly aligned. Now, since this is a double needle suture, this has come out. Now the next needle will come from the extra-iliac vein into out. As you can see, it has come into out. And now this is a policy based on surgeon practice, where some surgeons would like to just keep the kidney in the fossa and would like to anastomose. This is our way of doing it, where the assistant, which is standing in front of you, holds the kidney with the renal vein between its first index finger and middle finger, where the renal vein lies in between them, and there is a ice sludge over the convex surface of the kidney. The cranialmost suture is tightened. We'll generally take 6-7 knots. And now, as you can see, we'll take the caudalmost suture. So this is the knot, the caudalmost thing. And now we would have one suture on cranialmost side, one suture at the cranial caudal side, where both of the sutures would be under tension, so that it gives a wide, proper, aligned vein. As you can see, this would be a natural lie of the kidney. The first stitch is very important. So as I would like to pause over here. So two important points here is that you should overcorrect your angle first.
I will interrupt here 1 second, just pause.
Yes.
When you are doing this, because I also have seen the BV Ramaraj sir and K Ramaraj in Care Hospital, where I learned after coming from PJ, they will take one stitch in the middle of the vein, so that it will be always separate and wide mouth will be there. On the opposite side, for example, on the towards the assistant side, middle of the vein, they will take one bite, and that bite will keep it open. Otherwise, sometimes by chance other side cannot come. Does it have any meaning or not necessary?
So that is a 4-point fixation technique, where this angle is taken, this midpoint, this point is taken, and these are just a stage suture which keep your vein wide. Our way of doing is that we do a wide venotomy, so that the posterior wall never comes to you. Once you have taken 1 or 2 sutures, it has been my experience that if you take 2-3 sutures, you will see even in the right side. I'll show the video where you can exactly see where you are. So if you take the track
After first 2 3 bites, it will be difficult. After that, automatically gaping will become.
yeah. So
Yeah.
my thing is that, see, if this vein has an anterior and posterior layer, obviously this vein also has an anterior and posterior layer. If by doing that we avoid taking this layer, what if we take both the layers of this vein? So we cannot do point fixation here and here also. So the best way to do is that you take 2-3 sutures under your vision, and once it happens, what happens is that as you see this video, you will clearly make this point out. So see, these I have over corrected the angle, and once you take 2-3 sutures, what happens is that the posterior wall of this renal vein retracts up. So as you can see, you can clearly see the posterior wall of this vein also and this vein also. I hope you appreciate seeing, sir. So now, as you see,
Yes,
as
yes, I can appreciate the upper lip of the donor vein is gone up. It is retracted,
yeah,
whereas
so
the
now, yes.
suturing part is pulled down.
So the other tip and trick over here is that one technician would be standing on my left hand side, the cranial side of the patient, and he would be giving traction to the suture towards him. And that is how both the wall, can you see the posterior layer here? So if he gives traction now, what will happen is that the posterior layer of both the veins will not come in your way. Now, even if I don't see the posterior layer, which is very difficult now, which I'll see, it will never come in the way. So it's hardly a problem, this problem I've faced, that I've taken the posterior wall. So, and it should be an equidistant suturing, and it should be properly placed. That is a very important thing. So as this, now I think you can make out the posterior layer of the vein. Can you make out, sir? So this is an area which is translucent, and this is the area which is opaque, and this is the margin. Can you make out the posterior layer, sir? Dr. Chandramohan, sir?
Yeah, 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 yeah. Hello, Abhijit.
Yes, yes. Can you make
Yeah,
out,
I'm
sir?
following. I'm
So this,
following.
yeah. So this point I was highlighting. Now you can see the posterior layer, which is a opaque area, and this is an area where it is translucent. So the posterior layer has retracted, and now see what happened. You have two ends here, two ends here. So I have come with one end till around 3/4 of the vessel, and from the lower vessel, lower end, I would start suturing and would meet a point of around upper 2/3 and lower 1/3.
Yes, yes.
This is to prevent your knot to come at the angle. Where
Needle horizontal width looks big. What is the size of the needle?
it's a 13 mm needle.
Quite very
For
thick
vein,
and quite long it is looking.
yeah. So for it is only for vein. So for vein it is 13 mm, and for artery it is 9.3 mm.
60.
It's 660 probably.
Okay.
So now I am not able to see the posterior layer of the external iliac vein, but I'm quite confident that it will not come in the way. And now I'm hardly touching the vein. It's just the suturing that I'm continuing.
But here I again re-emphasize, you are taking both the bites together. You are
Yes.
confident that the posterior layer like in pyeloplasty will not come.
Yes, sir. Just because by this time my anterior layer is given traction both by my assistant and by me, and my posterior layer has gone behind.
Okay.
And as a precaution, I would come across my first stitch and then I would tie the knot.
Yeah, yeah, understood. Very nicely recorded. I must appreciate recent recording this is.
Yes, I think a month ago.
Yeah, very nicely recorded. After my request, you have recorded once.
No, just before your request, I had recorded this a week ago.
Oh, fantastic. Very nicely. Except the knotting time video cannot show. Otherwise, I must say it will be useful for the beginner also.
Yeah. So now this is your peritoneum, which you will reflect with your retractor, and now your kidney will come in the fossa. Your both sutures can come. See, so what we'll put a slush below and above the kidney. One, to maintain the cold ischemia, and second, it gives again a length to your vein, so it is not crumpled. And the beauty of this vascular clamp is that you can align your extra-iliac vein the way you want it. Okay.
Yes, you can rotate. You can rotate anteriorly and posterior.
Yes. Now I think, sir, you can make out that I have not at any point of time taken the posterior layer.
Yeah, very. There is no doubt. But in the middle part, when we are suturing, You are confidently taking, but I was trained like that, so I was getting doubt.
So the thing is that as I've had a discussion with many surgeons, so
No.
in private practice, if you don't have trained technician with you or residents with you, it's always better to take this 4 point fixation.
Acha, one
Now we
question.
are
Now you are taking reverse bite
yes.
in the this thing. Why not a forward bite?
So this is a point of preference. So at our institute, Sabni sir does it the forehand way, and MRD sir does it on the backhand way. And I've been it's just my personal preference that I do it the reverse way. So first I have come
Bite
out
of the every bite of the donor kidney you will do in reverse.
for the other side of the vein. And I'll tell you the why do I do it this way. So now the renal vein I have come out to in, and again they have taken a forehand. As you can see, I have overcorrected my angle.
Yeah, I got the
So,
point.
yeah,
This angle overcorrection is very important, and
yes,
spatulation 2-3 millimeters more is more
yes.
important for vein. Everybody says.
So it is my there are my two thought of my doing this the backhand way is because as you will see, so you will not appreciate for the first one or two sutures, but see, as you keep on doing it, the assistant in front of me just retracts the vein, and for initial 2 or 3 sutures, I need to hold the vein, and as you see, the retraction part will itself suffice my purpose.
Okay, but logically it doesn't make any difference in terms of suture fall.
No, there's no problem if you do it forehand or backhand. There's no difference. It is just a surgical preference. So you can see, make out, I'm not touching. It just increases my speed and precision. That's all.
Because other side of the vein is lifting up now because of the
Yep.
reverse direction.
Yep. Yeah. Yes. Yes.
Yeah, see, other
See,
side is lifting and the space is nicely seen.
yeah.
You are going
And
quite fast.
other thing is that as it is my personal experience that doing backhand gives me a flexibility of deciding where my needle will come out of the vein.
Mm-hmm.
But your assistant at the same time should match your speed also and should give a good retraction. Now, see, once I've done this way, I am outside of the extra iliac vein.
Yeah.
And now I'll again, as I said, we do the knotting in the middle of the vein. I'll start my suturing again from the caudal end of the vein.
The instrument which you are using is flushing as well as aspiration.
No. It's just a flushing instrument.
Only flushing instrument.
Yes. So the camera has gone out of focus.
Now,
Again, the angle which is taken.
now you are taking backhand here.
No, this is forehand.
Sorry, forehand. Forehand you are taking.
So this is forehand, so that now I will end on the donor renal vein. So when I tie the knot, both of my sutures are on the opposite side of each other.
Opposite side. So that exchange need not be done at the end, in the middle.
Yeah. So if I would have come
Forehand.
I would have both the sutures would be on the same side of the vein.
This is a point to be noted. Very important.
But I don't think it would be of any consequence or not.
No,
But
no, it
just
will have because it's a continuous suture. Once you come reverse hand, when you pull, an exact energy may not be transmitted to entire length of these stress.
yes. And this is now I would like to make this point. I've taken this suture and see. I've inserted see how well it is distended. There are two purposes of this. One, it makes me know that there is no leak in the venous anastomosis or in the vein branches. One, and the second, my posterior wall has gone way back. So once I take this suture, it will not come in my vein.
You will cross the suture?
Yes, I'll cross the suture. And now once I tie it, I'm quite confident that once I release my venous clamp, there'll be no leak.
Okay. Will you release venous clamp now only and apply a bulldog at the
Yes.
now only, right? That is
Yeah.
what also
Yeah.
practice, and so that you can see the leak. But that will be
Yes.
Um, under pressure, no. The
So there are three checks where we do for the leak. Is once on the bench we check for the leak.
okay.
Second is this method, and third, the more proximal you apply this clamp, you will come to know the leak. So see, if I apply once, you have to apply this clamp over the vein,
Yeah.
and see the way the artery should not come in the clamp.
These
If your
clamps you use all Martin company or something?
Asculab.
Asclap?
So one thing I would like to make a point here is, if you are interested in vascular anastomosis or kidney transplant, always and always invest in good instruments,
Yeah.
because these bulldogs will determine the outcome of your surgery.
Outcome of this.
Whatever efforts that you take will not be translated into a good outcome until your instruments are good. If this clamp is bad, the patient will end up in intima injury and renal vein thrombosis. And the point to be noted is that you can see the artery. You make sure that the artery doesn't come in this. So if your artery comes in this, there is no point you can release this clamp. If you release this clamp, blood will go into kidney, and your artery anastomy is yet to be done.
Oh.
Then the blood will clot in the kidney.
Yeah, that's not good.
Yeah, that's not good. So you always make a point that, so you can see there's no leak.
Yes, yes, yes.
So this is how the left.
But sometime when you release a small amount of leak will come on gauge piece will keep for 1 minute and it will stop.
So
ideally leak should not happen.
So this is the beauty of vein. Even if there is small leak, just leave it alone, put a gauze. Why? Because vein is a low pressure system. Now once you have given the way, you have opened the clamps, your extra iliac vein is now open for the blood to go in. So that is why your small leaks will stop, because it is a low pressure system.
Yeah.
Now coming on to the right side, which is the most challenging side. So because there are instances where we have only a 10 mm or 8 mm, 9 mm of renal vein. At point of time where at anastomosis, the renal vein, which is actually in the concavity of the kidney, it's not even coming out of the convex borders of the kidney. So how do you tackle this problem? So that is why I have given a small video where your bench is also very important in this case. Okay. So bench will determine your outcome. So obviously, as you know, that if it's a right kidney, your vein would be towards you. And now you need to see. So see, this is the renal vein that we have. So I kept this video after the left side just to highlight how small the right renal vein is. Right. So now this is the flushing which is going on. This being an unedited video, I'll just go ahead. Once we have flushed the kidney, we'll focus our dissection towards the renal vein. Yes. So now the aim of the dissection is to remove the loose areolar tissue near the vein, and also to tie up the tiny branches of this vein so that it comes out of the hilum and gives you a length. Points to be noted. You have to do patiently and till the base so that it will come out. Yeah. Point to be noted here is that during dissection, you should be ultra careful so that you don't injure any of the venous branches. So if, as you saw in the left side, you apply the clamp, and if there's a small leak, you can repair it. Now just imagine this is a small vein, and if it leaks from somewhere, it is very difficult because your graft is relatively very fixed to extra iliac vein. In a left donor vein, your kidney can be flipped here and there. The suture size here, silk? So this is our suture material, which is 30. 30 silk. Yeah. This is linen. So now the point to be noted here is that this was a donor where it was around 11 mm. So we applied a clip. And after, as you know, that if you apply 2 clips and cut, around 5 mm of length would be lost. But with the dissection, careful dissection coming out of this fossa, see how it is almost 2 centimeters now. Fantastic. Now, the point that I made is that you should know that we need to check the leak of the vein. So how do we do is that, so this is the dissection of the artery. So this is the point that I need to know. So this is the artery. So what we'll do is we'll take the cranial and caudal end of the vein, apply a bulldog to the venous bottom, and this is how we'll apply it. And now you flush the renal artery with saline.
Oh,
Now see, the vein will distend very good, and if there is a leak, it would be quite evident. And if there is a leak, you can repair it at this point of time.
okay, very nice.
So whatever there's a problem, just solve it at this stage of your surgery. You see, it's quite distended, it's
Very nice.
bulky, and there's no leak.
These bulldogs should be very good at the tip you are applying.
So if for the left side, what we do is generally, if we hold it with your fingers, see how the big this renal vein has become now.
Thin also.
So the right vein, and if the donor is a female, the veins are very flimsy. So, and the point to be noted on the right side is you need to have the proper orientation. Your ureter should be caudally. Your first attempt is your best attempt.
Okay.
If your assistant gives lots of, see, your assistant also needs to be very careful. If he gives a lot of traction, there would be tearing of the vein, which is very easy on the right side. And once you have tearing of this vein, then you are slowly almost to be doomed. Because once you lose all your venous length, then it's a grave problem.
Yeah.
So on right side, prevention is the best thing.
Yeah.
So now, as you see.
So very carefully, the assistant has to keep close to by weight gravity, not retracting too much, not falling.
So as I said, your index finger and middle finger of the assistant, from which you can see the vein, appropriate traction, and here you should avoid taking the posterior layers. So as you can see, small bites, over correction of the angle, and
Fantastic.
right side anastomosis should be a very careful anastomosis. You take your time. If you take a time doing it properly, major of your time handling the complications would be saved. As you can see here, you can see the posterior wall of both the renal veins.
What is the loop magnification?
So I use a loop which is 3.5x.
Which company?
So it's a local company. I am yet to order a killer loop.
Yeah. Local company name, no conflicts of interest, just for the audience sake.
It's RK Medical.
RK Medical. Okay. It is like spectacles.
Yeah. So
individualized to you or anybody?
No, it has my number specs.
Okay, right.
So as you can see, so what I'm trying to show here is that, see, as you can see the posterior wall of the vein.
Yeah.
So my point is, even on the right side where the renal vein is so small, you can still make out your posterior vein.
I got the point.
And you and I think can very well appreciate the thickness of the extra iliac vein versus the thickness of the renal vein.
Yes, yes. Transparency is seen in the vein transparency is not there.
Yeah, so you have to be very careful so that you don't injure your sutures. So there should be there's a synchronous movements between both your limbs.
And you are not holding the vein as you come to the middle.
Yeah.
In the angles only, your overcorrection, that time only very important.
Yes.
As you come into the center part, it's coming free flow.
Yeah. And at no point of time, you can see I'm holding the needle with my fingers.
Yeah.
It's just needle holder to needle holder. As I said, this is an art. Transplant surgery is an artful thing. So as you can see, the sutures are equidistant placed and they are very well placed. It should not look like zigzag. One suture is here, one suture is there. It should not be that way. And now it's overcorrected. And now you can tie the knot.
What are the situations where seeing both the sides of the vein and suturing will be difficult?
I didn't get your
now you are flipping the kidney towards your side and then the anastomosis. Which conditions it has become very difficult? Deep cavity, obese patients, pelvis.
Obese patients would be difficult. So in obese patient, what we do is that we'll be ligating the internal iliac vein. So that brings your extra iliac vein out of the fossa.
Okay.
And it is my personal preference that I would like it to intra-iliac vein only when the patient is quite obese, if my vein is not coming out. So as you can see very well, the both layer. Now again, the assistant should avoid traction over your kidney. So this being a right side, I have chosen doing a forehand vein.
Because you will not have much space with the fingers.
Yeah,
Who is holding your kidney now? Assistant again?
yeah. This is a technician Navneet Bhai who has assisted around 4,000 transplants.
Okay, he see his fingers are just fixed. Like, oh my God, on the vein it is fixed. And he
Yeah.
one finger in the middle finger, I think, is keeping it down. That is also
Yes.
not.
Yes. It's always great to have a great team with you.
Yeah, yeah,
That
yeah.
just makes your life simple.
Yeah, yeah, yeah. There is no doubt
And
about it.
that is how we almost finish our transplants in 3 hours, 2.5 hours to 3 hours.
Very nice. This is unedited video and we can identify the each step.
So there
You
is
put a small gauge piece folded so that the kidney will fall on the psoas and the gauge piece nicely.
yes, yes. So as I showed in the previous video, we'll keep a ice sludge below the kidney and an ice sludge over the kidney. So as you can see, there's hardly any manipulation of the vein. Neither am I holding the needle.
Yeah.
And it should be a very delicate synchronous way of suturing it. Your suture should be equidistant.
Around 3 mm bites, 3 mm gap.
1
Roughly.
mm. 1
Huh?
mm. 1
1
mm.
mm.
So, sir, to give it an idea, this
No, I
vein
am asking the distance between the suture is 1 mm only.
1 mm, 1 mm. 1 maximum 2 mm.
Yeah.
So in vein you can have a slightly more distance, again as it being a low pressure system.
Yeah.
But still to be on precautious side. So as we said, the more precautious you are doing the anastomosis, your life becomes easy after it. So imagine a situation where you have declamped it and your vein is leaking, your artery is leaking, you are asking whether urine output or not, and becomes a hell lot of problem.
Yes, yes, yes. Correcting vascular, again reclamping and again flushing is very difficult.
Very difficult. So it's always better that your anastomosis is foolproof.
Better take time and do meticulously.
Yes. So again, you can see I am correcting my angle. So this being right side, I should be completely sure that once I remove my clamp, there will be no bleeding.
I will ask a simple question. Stretching and doing half centimeter extra anastomosis is better, or non-stretching half centimeter lesser anastomosis is better in the vein?
I think the stretching is a good thing, but it should not be overstretched. So what happens is that if you overstretch it now, what happens is that
Thrombotic. Thrombotic it becomes?
No, it doesn't become so. So again, you can see the vein is well distended.
Yes.
This is my way of understanding that it will not leak. So if this is a lot of stretch, what will happen? This angle suture from the renal vein will create a tear.
Okay, because of the thinness
yeah. Once you remove the clamp, this angle will leak. There you will have to take a figure of it suture. Okay. Now, as you know, as you see, I am less worried that I'll take the posterior layer in this thing. I have overcorrected my suture and now I will tie the knot.
Because of the distension, you will be less worried?
Then, because of the flushing of the water that I've done, flushing of the NS.
Many of the surgeons will release it and then suture like this or distend with system. In AV fistula, we will release and then last bite we will take and then.
So, putting an hypernized saline is always a better option than blood because it doesn't give a messier feel. So you can see my bulldog is very well moving and I will declamp my vein.
Very nice.
So I'll put just a gauze and that's all. So obviously you will have some amount of ooze because that is because of your needle pricks.
Yeah.
So now I think this gives a fair idea of venous anastomosis, a left renal vein and a right renal vein.
Fantastic.
Now coming on to the next part of the talk, which is arterial anastomosis. So yeah, arterial anastomosis could be a single artery, double artery, or multiple arteries. So the choice of anastomosis is again, as I said, it could be an end-to-end to internal iliac, it could be an end-to-side to an external iliac, or if there's a double vessel, if it's a diseased donor, then you can have a Carroll's patch. If it's a live donor, then obviously you have options of internal iliac and external iliac, internal iliac plus inferior epigastric. And if the two vessels are of the same size, you can do a bench surgery or by doing a pantaloons and a single anastomosis. Or if you have multiple arteries, as you can show, you can see the picture.
Yes, yes, beautiful.
So these, as you know, this is the intra-iliac artery. So this is the
Yes.
intra-iliac artery. These are the distal branches as you go towards the bladder. So
Yeah.
what I've done is I have ligated all the distal branches and I've cut the proximal branches. This
Yeah.
is the extra internal iliac side. So what I can do on bench is I can anastomose the multiple vessels to these outlets, and then again I can anastomose it to an extra iliac or an intra iliac.
Yeah. That means anastomosis with the branches he will do bench. After that,
Yes.
only the main anastomosis he will do
Yes.
with the in situ graft.
Yeah. So this is known as interposition graft of intra iliac.
Interposition
As you can
graft.
see
Yeah.
in this image, you've
Yeah.
ligated a distal. Now you have this is for bench, and see you can see you will again anastomose it too.
Yes. Yes. Yes.
Okay. So now I will show an internal iliac, extra iliac, and an inferior epigastric. So,
Fantastic.
so the principle, as I said, vascular anastomosis has principle. So if you are doing an end-to-end anastomosis of two tubular structure, it has to be a opposite side spatulated anastomosis with one suture on each angle, and then you stretch it and take a suturing. So first, this is an intra-iliac artery. So as I said, we have dissected the internal iliac artery. Now this is a Satinsky vascular clamp, and the point to be noted is that I will never ever apply this clamp on the internal iliac artery, neither on the junction of internal iliac and external iliac. If you see carefully, this is over the common iliac and on external iliac, taking the point that it doesn't occlude the blood supply to the distal external iliac.
Yeah. Yeah.
As you see it,
Yes.
so now the clamp is
Gain
applied.
maximum pull of the internal iliac artery as well as elasticity, so
Yeah,
that you need not forcibly pull the artery.
yes. Now what I'm interested is in two things. One is orientation of internal iliac artery. See the flow. What I've checked is the flow in the internal iliac artery is very good. So external iliac artery obviously always has a good flow. The internal iliac artery, you need to check the flow. Now I'm quite happy with the internal iliac artery flow. The problem in the internal iliac artery is that lots of branches. So you need to cut off the branch so that it's not good to have this branch in your anastomosis. You need to have a clean cut while you anastomose. So now, as I said, you need to spatulate on the opposite sides of the tubular structure. So this is the donor, the recipient internal iliac artery. I have spatulated it and I have cut the ears of the intra-iliac artery. This is a vascular pot ring forceps, and this is a pot scissor. Now, once we have done this, I am ready with my intra-iliac artery. Now, so I have spatulated the opposite side. As you can see, this is spatulated on this and this is spatulated on this side. Okay. Now, this is a 960 Prolene 9 mm needle. This would come from here, would come out here. Again, it would come from out to in, and again it would be into out. Okay. And the suture would be out to in from this and come again this, and again this to this. So you will have two sutures and not tied on opposite ends. You can very well see in this video. So you have to be sure that this is exactly opposite to the side of your spatulation. I think the video is self-explanatory.
Yes, yes, yes. Very, very. Outside in, inside out. Inside.
Yes. Now again, outside in, inside out. I'll tell you a benefit of this technique. We tie the knot. So there's no need to do it again. You can just tie the knot at this point of time also. There's no need to do it twice.
This is only, sorry again, I am little confused here. This is only one side needle.
Yeah. No, it is a two-sided needle.
Two side needle.
Yeah. There's only a single suture.
Yeah, single suture. Okay.
Yeah. Now I have put a mixture, and this has given traction to the suture so that this suture does not come in my way. Now I'll cut the ears of my donor artery. Now again, this is into out from the donor artery. Basically, the thought is to keep your suture, the knot outside the vascular structure.
Yeah.
It's come out. What I'll do is with the other needle of the same suture, I will again come into out of the internal iliac artery. Now this is the other needle of the suture, not the same needle of the suture.
Yeah.
This is the other needle of the suture, just opposite the side of the spatulation that we have done in the internal iliac artery. That have come out. Now I'll take the previous needle. The previous needle again out to in of my donor artery.
Okay.
You can very well make out just the small tip that we have cinched the thread with the mixture, and this is made your life so simple. You can very well see without touching the vessels, both the ends of the vessel.
Yeah.
And now your planning is done. Now you'll remove this mixture and cinch your both sutures and see what happens.
I wanted to repeat this. Can you go back if you don't mind?
Okay.
From the beginning, can you explain? Because if I don't understand, there's a chance that from beginning, please. From beginning.
Okay.
After you take the first suture. Yeah. First suture enough.
Okay.
Forward first suture. Yeah, flow checked. Anteriorly, you have spatulated.
Yeah.
Here is spatulation already done, but the ears are not cut. Now outside in anti-spatulated area of the graft.
Yeah.
Now okay, you are going outside in now. This is a 2-arm needle.
Yeah.
Yeah. Now what are you doing?
Now this again comes to the V of the
Same
spatulated end of the
same needle.
Same needle.
So outside in, inside out, simple suture.
Yeah, simple suture.
And now other side needle, what are you doing? You are keeping outside.
Simple suture. Again out. Same. I'll repeat the same thing. Out going into out.
One more bite you are taking. Yeah. Next bite anteriorly, whatever that faces.
Yeah, it's just adjusted to the previous suture. Out to and into out.
Out in 2 bites you are taking with same needle.
Yeah, and I'll tell you the benefit of doing this thing.
It stabilizes probably the angle.
I'll show you once the video.
Yeah, okay, no problem. So outside in, inside out, 2 bites you have taken with same needle.
Yes.
Okay.
Now this finishes one angle of your anastomosis. Okay. Now to prevent entangling of the sutures while you take the opposite angle, we put a mixture so that this sutures are away from the next suture that you will take.
So now, next is a separate needle.
Yeah. Now this is a separate suture.
Separate suture.
Okay. Now this is a separate suture. Again a 2-arm needle. This is a donor artery into out.
Into outer.
Yeah.
At the tip of this spatulated area.
Yeah. Now this is the opposite. This is an opposite needle of the same suture. Sorry. Again into out.
Yeah, into out. Same like outside in 2 times you are taken. You are also taking here again. Other end with separate suture, separate with one needle, in out, and then in out.
Yeah. So now you can do whichever ways you want. Just
Okay,
you have
okay.
to repeat the
Whatever
same process.
yeah, whatever the way you are showing, in out.
And again in out.
Okay, this is at the spatulated end of the
Graft. Graft.
yes. Now understood. Fantastic. We are not doing like
You
this.
have to the crux is that you have to repeat both the steps at both the angles with 2 different sutures.
Okay. One outside, one inside out.
This is our way of doing it. Whatever suits you, you can do it.
It is opening up like this.
Yeah, so I'll show you. See, now what has happened is that, do you appreciate the pouting of the
Pointing over,
axis?
yes.
So at never a point of time during anastomosis will the edges go inside.
Yeah. By taking 2 bites, they will be averted, you mean to say?
Averted, yes.
It's like a flower, it is opening.
Yes. I just may go forward, just the knots that we are taking. Okay.
No problem. Okay.
Yeah. So now there are there's one suture here, one suture here. There would be 2 arms here, 2 arms here. Agreed?
Yes.
Now with 1 arm to 1 assistant and these 2 arms with 1 assistant, I'll take 1 needle from this arm. I will start the suturing.
Okay.
Oh, sorry.
No problem. Inside out. So anyway, both are outside. Now you are taking one needle of the two.
Yes, from the cranial side or the whatever side, what do you call this side? From one side, you can see the edges are very well everted.
Yes.
Now there should be minimal handling. So if I hold this is the serosa which is hold with my forceps. The first suture would be at angle. Now am I holding just with my left hand and managing my suture in the graph with my needle.
Because it's already everted and approximate.
Yeah. It's everted, it's aligned, it's planned. I have to just do the suturing part of it.
Like a skin suturing you have to do.
Yes.
You need not worry about the lie, you need not worry about the approximation, cheating, everything.
So if you want your junior to do this anastomosis, you do this step and then give your junior.
Yeah.
Then you can just do the suturing part of it.
You cannot go wrong because it's in front of you.
Yeah, the planning is very important and you've done the planning.
Right.
But here also what is important is that minimal intimal handling, 1. Second, equidistant perpendicular sutures to your vessels, all through layers of your vessels. At no point of time there should be intima which is left behind, and there should be proper lie of the sutures. So as you can see, once I take the suture, when I cinch it.
And only thing is where to spatulate exactly back to back, you should be careful.
Yeah. So when yes sir.
I mean, do you have any fixed position like 9, 10, whichever comes to your face is 9 o'clock like that? No need to see. Lie of the artery, I am telling both the lie when you are spatulated.
So in internal iliac artery, that spatulation will depend upon the lie of your vessels.
Yeah. You have to approximate them and see how nicely they are coming without.
Yes. So
you are not I'm sorry, I'm interrupting. Don't mind. But you have not applied any bulldog at the artery of the graft.
No, that's not needed
That's not needed.
because there's no inflow of blood.
Yeah. No, no, just to avoid the rotation if it is a long artery.
Yeah. So, so this is quite a foolproof method. Never ever have, at least I faced any problem by this technique.
All the needle tips are round atraumatic one only. You don't take normal
Yes.
ones.
No.
Fenestrated round tipped
Yes.
from the aspula.
Yeah. So now I've come at the angle. Now I take one of the sutures which is available and I'll just tie it up. This is one side of the anastomosis.
Yes.
I hope the video recording is okay.
Yeah. A lot of effort is taken because deep cavity anastomosis recording, who has recorded also must be mentioned. To be honest, he
So
should.
we have an audio visual team. Mr. Manoj has done this. Manoj Makwana.
Yeah, this is a surgery must be understood also by the recording person.
So now I would take this suture with the mixture, and this suture comes out from this side, and all the three sutures go on opposite side. I hope you understand this.
Yeah.
Now, the first step is to look whether they've taken any edge while doing an entry anastomosis. I will flush it with saline, hypnized saline on both sides. This is patent. Graft is patent, and also my internal iliac is patent. I think that's evident.
Yeah.
Now, with one of the sutures from the above, I would again start the suturing. So basically, I am as a surgeon facing the left side of the patient if the graft is placed in right iliac fossa.
Yeah. Everything is forward.
Yeah, this is forward.
Both that also, this also.
Yeah.
Only renal vein other side you have taken reverse bite off of the, except that everything is forward bites.
Yes.
Lot of surgeons prefer forward bite, no right-handed surgeons.
Yeah. And you can see it is a synchronous thing. It's just a needle to holder needle passage.
Is there any tips for the fall of the thread properly 1 mm 1 mm while pulling out? 45
it is
degrees,
90 degree.
90 degree.
So it should be 90 degree to the vascular edge. You can make out all the lines are equidistant around almost 1 mm and they are perpendicular to the vascular edge. So you can see I'm hardly holding the intima. I'm just holding the serosa of the vessel. And that too graft I'm not holding.
A basic doubt I will ask, why don't you do the renal vein type where anastomosis, where knotting can be done in the middle of the artery?
In the artery? So if I were to tell you this, if I start the anastomosis from here, there is nothing to hold the artery over here. All the orientation of my artery would be lost. This is sufficing because there are two sutures. So the problem in intra-iliac artery is that this artery is mobile. So that is why you see a majority of the robotic surgeons do anastomosis with extra-iliac artery just because the intra-artery is mobile.
Once it is mobile, it is difficult.
Yeah, extra-iliac artery, the artery is fixed. So this artery is fixed during my anastomosis because of two opposite end sutures which are held by two assistants.
Okay.
So if I were to again take this thread, there is nothing to hold or give strength to my artery.
No, yes, I got the point. At the angle also you are not holding because the everted edges will be nicely seen with the loop.
Yes. The placement of
94%.
sutures is also very important, as you see this at the angle I've taken. Yes, sir?
99% of these times the internal iliac artery when you are doing this twisting will not be a problem.
No, never. So if you do all your checks properly, there should not be any problem in a transplant.
Yeah. I mean, steps should be repetitive and then must be learnt with practice.
Yeah.
Maybe on the
So
glance or.
the crux is that you keep on doing the same step for the same number of time.
Yeah.
So in my experience of around, sir, 400 transplants, this is done the same way.
Very good.
And
On an
now
average, yearly, how many transplants you do?
150 to 170.
Nice.
Now I will just revert back to its original thing. Now you can see the lie of the arteries properly. So see, it is as if God has given you this organ. You can very well make out.
Yes.
Now once you remove it,
Smooth curve is there. Smooth curve.
it's a smooth curve. There's no kinking, there's nothing.
Hello?
Yes, sir. So this is just to show the urine
Abhijit?
output. Yes, sir. Am I audible? Am I audible?
In between, it was lost.
Now
Yeah, you are audible. Only thing is, hello?
Yeah, yes, sir.
You have finished the artery in between 1 minute, it did not get connected. See what happens in Zoom if you continuously talk for half an hour, 45 minutes, then it gets disrupted.
Okay, so this is just I'm trying to show the urine output of the same patient.
Okay. That part we missed.
Yeah, okay. And now this is the final lie of the graft. As you can see, this is the vein and this is the artery.
Yeah. Fine. This is fantastic.
And this is the ureter.
Fantastic. Very nice.
Okay. So now this was internal iliac artery. Now coming on to external iliac artery. So this is an N2 side anastomosis. So N2 side anastomosis, the steps involved in external iliac is that first you need to do an arteriotomy. Then you have to make the appropriate length and size of arteriotomy, and then spatulate your donor artery and do the anastomosis. Sorry. So doing an arteriotomy is there are ways of doing this. Is first you can use either a 15 number blade repeatedly at the same area and do an arteriotomy, or you can keep your 11 number surgical blade with an angle of around 45-degree, poke inside and just remove it. So the worry of people, those who use this blade, is that they are worried that this tip may injure the opposite edge of the vessel. So if you are used to whatever ways, you can do it that way. Then you can increase it by pot scissor and do a proper arteriotomy with a punch. And then this is a spatulated end of your donor artery. So now this is known as heel, and this is known as toe of the anastomosis. So so this is we do it the other way around. We start from the toe and come to the heel. Okay. So now a very important thing when you do an external iliac artery anastomosis is a punch. You always try to use a punch. The punch should be properly used so that it takes all the layers of the artery. It should always be a single use punch of a very good company, never be reused, for the only reason being, once you fire a punch, and just imagine that the punch does not negotiate back, doesn't disengage. You have a punch which is just stuck up to your external iliac artery, then what will you do? So this is the punch that we use is from Teleflex company. These are reusable, not cost 1,500
Which company?
rupees.
Which company?
Teleflex company.
Teleflex.
Yeah. So they are not so costly. 1,000 and 1,500 for a transplant is nothing. Always use a single use punch. And they come in different sizes. If you have a double vessel, it's a small vessel, you can use a 2.8 mm punch. If it's a single vessel, we use anywhere from 3.64 or 4.4 mm. These are usual for a single artery. So coming on to the principle is that is internal iliac artery, the intima should always be fixed. So as I come in the video, one layer will always be an into out, when the other layer can be taken out to in, but your principle is that your intima should be fixed. If
But
there
people
is,
say Intima, sorry, people say Intima will be fixed if you take inside out properly, because
yeah,
you
yeah,
can go 3 to 4 millimeters edge inside the
yes,
lumen and then
yes,
transfix to
yes,
the adventia.
yes.
So it is it logical to go inside out entire bites?
Yes. So if you can do it, if there is no or no arthrosis outgoing can be done, but it's always safe to do an inside out, depending upon the experience. So now this is, I'll try to evaluate all the steps of external iliac artery. Now this is the vein which is already done. This is the clamp of the vein. Now this is the external iliac artery. I will spatulate the caudal end of the artery,
Okay.
getting the ears of the donor artery.
Okay.
Now I need to plan my arteriotomy location.
Yeah.
So these are my slings. One is proximal sling over the external artery and a distal sling over the external artery. So I'll be having two slings in external artery. Now I'll be applying a clamp over my distal end. So point to be shown is that I have not dissected this middle part of the artery. I have dissected on the part where I put a clamp, and just above where I have dissected to put my clamp. So I have only dissected that much area where my clamps can be. And I want to like one highlight one point. Once I'll show the point where it comes. So again, these are from Vasculab company. Always try to use a good quality vascular clamp. There have been instances where you have external iliac artery stenosis away from your anastomosis, and this is just because of your clamp bulldog injury. So now what you need to do is you need to plan the location of your arteriotomy. So this, I'll just go back. So I just saw where it places comfortably the lie of my donor artery. And now once I've decided this, see, I'm almost 45 degree to my external iliac artery. Just when I go inside, I will never go deep inside, and I will just try to come out. So that will give me some length to my arteriotomy. Now the
One
further
more small interruption, because this is the only step which is stop it.
yes, I've stopped.
This is the only in AV fistula. What I do is needle pass through the artery and then come out a few millimeters away and put a 11 number blade and then come transecting the part. You're understanding what I'm telling?
I'm getting a point, sir. But it's just a matter of preference. Even in radial artery, I do the same way. So
This cut is even radial artery also, this type of cut?
yes. So my tip would be never go more than 45 degree. Be slightly slanting. If you try to
Yeah.
be vertical, you will injure your posterior wall. Just be slanting. Just enter your artery. Just enter your artery. Always use a fresh blade. Always use a very good company fresh blade. This should not be used anywhere in your surgery previously. Be slant, just enter and come out. That's all. Don't
Yes,
go
yes.
inside.
One question is asked because we may not at the end may not get time. By Vikram Prabha, what is the name of the needle which you are using for flushing and what is the size?
So I don't actually know the name of the needle. It's just a flushing needle that we call. So
What
at
is
the
the size? Size and
size,
company.
so the size is this is just a soft end at its tip. The size it would be around 2-3 mm.
Yeah, yeah. I think it comes uniformly one size.
Yeah,
All the renal transplant and company is local company only.
yeah, almost local company.
Yeah. Now show the.
So this is an important point is that I have increased, sorry, I have increased my arteriotomy. Now, very important thing is about your this
Buttonhole.
satin aortic punch. So the
Yeah.
punch is that your arteriotomy should be sufficient enough for your punch to go in. So the punch that I'm using now is a 4.4 mm punch.
Okay.
Now
Slowly.
the way to do this is that, see, this is a diamond cut tip of it.
Yes. Yes.
This edge should go into the artery, into deep to intima. It should never dissect through the walls of vessel. You should clearly see the intima and go deep to intima from one side, go on opposite side, and then insert the other side. If you can see, I've gone inside again. See, did you appreciate? I went
Yes. Yes.
inside,
Yes.
came
Yes.
on opposite side, and then I need to see whether it's freely mobile. And you can see it is a Teleflex 4.4 mm punch.
Yeah. Yeah.
Now I need to lift the artery. I come to know that it is freely mobile. I have engaged it. I need to lift the artery, fire the punch, and then I can get a very good donut of it. So you can see the donut which is lying over there.
In fact, you should
Again a
go
flush.
deep in the lumen and touch opposite side and then lift and then feel the movement. What you
Yes.
mean to say?
Yeah. And now I'll just remove this. Now there are two ways of extending is that you can again engage your punch. You can use half the size of your punch and again fire. I think got the point, sir.
Yeah, yeah.
So you can increase the arteriotomy by either using a pots, but the problem with pots is that it will not again increase, you make your arteriotomy wide, while using just half of your punch, it will make it properly. Now the point that I want to show is here, I put my clamp distally and I have not dissected this artery. You can see there's a blood which is coming.
Yeah, yeah.
So with this thing I noticed, and this should never happen. The blood should not be coming over there. So what the problem is that there are feeders to the extra iliac artery from the muscle.
Yes. Yeah.
So either you dissect it off completely, or if you don't want to dissect it completely, put your clamp here,
Close to the.
close to your anastomosis.
Same happens with the artery in the AV fistula also.
Yeah.
Slowly ooze will be there and it annoys the anastomosis.
Yeah. Now, as you see in this video, I have applied the clamp over there, and suddenly you will see there's no blood inside now. Okay.
Okay.
Now the point I need to show here is that it has not come in the video. Is that I have taken the angle of the donor artery and angle of the external artery, and I've tied a knot. I am outside. Now there are two ways of doing external artery. Either you flip your, you do this side, then you flip your graft to the opposite side, do the opposite side. Okay.
Yeah.
Or you come from out to in of your donor artery and do the anastomosis, just allowing your graft to be in the fossa. So I have come from out to in the donor artery, and now I will go into out of my external artery and do my forehand suturing.
Okay. I got the point.
Yeah. So see, I came outside. So I had already come in the donor artery. Now I have come from external artery into out.
You have to go
it should
in.
not. The point over here is that your assistant should just hold the serosa of the opposite side so that it keeps your artery wide open.
Okay, okay, got the point. From the angle you are coming, take out the needle to your right hand, then outside in
Yes.
first point. Outside in
Yes.
first point.
Yes.
This needle should come from the most bottommost point and then start.
Yes.
Okay.
This is your angle.
Yeah.
And now you can continue forehand suturing.
Then all inside out, inside out, inside out like that.
Yes, sir. So at important point is that I should see my intima of external iliac artery. I am seeing the intima of my donor artery. I hope the video is seen well.
Yes, yes, yes. I can appreciate, and the number of the audience is increasing.
Thank you, sir.
They are joining after the last work because lot of PGs and assistant professors from the medical colleges watch after 5:30.
Yeah, okay.
Now people
So
are.
obviously it would be on record so that they can watch it at later
Yes,
point.
yes, 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 yes. That is the main advantage of this program.
So basically, my thought was to encourage and show this tip to the young urologist.
Yes, those who are interested in vascular as well as.
So I would, if I were to tell you, from economic point of view, you should never look at a transplant from an economic point of view.
Yes, yes, yes.
This is one surgery which you should do if you have a passion for.
Yeah, yeah.
Because this surgery should never be done in a haste. It's a responsible surgery. There are relatives waiting outside to look to your view as to what happened to two people that went inside.
Yes, yes, yes.
And you should be careful while doing this, as if you have dissection of your internal, the intima of external iliac artery, then it's very difficult to sort it out.
If at all length gets less on the external iliac artery, then you have to spatulate from above down,
Yes.
reverse direction carefully.
Yes. The one reason for some people to opt for external iliac artery is that the dissection for external artery is minimal, very easy, and as you see, the anastomosis part hardly has any planning in it.
Yeah. No.
As you could have appreciated the internal iliac artery video where there's some amount of planning in it.
Yes, yes.
If you do a fistula, you can obviously do this type of anastomosis.
This is almost like a
Fistula.
AV fistula.
Except in fistula, if there's a RC fail, you can do a BC. This cannot happen in transplant.
Yeah. Here, side to end to side anastomosis is same like fistula.
Yeah. So now I am approaching my angle. As I was taking both the sutures simultaneously, but I would like to differ during angles.
Lot of people say that when you take angle, you last bite you take little more breadth so that it will come and fix by the side.
Yes. So as you see, we'll go once ahead also. So we have taken this. I'll come through the proper spatulated end. And what we do at this point is that now we'll lock the suture. See, I've come through it and I'll lock the suture. Now, why do I lock is that? Because if I lock the suture, it will prevent the puckering effect.
Oh, this we didn't know. It will, the traction ends there itself.
Yeah, the traction ends there itself. So since you are doing it continuous with only one suture, obviously not this suture will continue, but obviously it's a circular anastomosis. But there should be a point. See.
Got the point.
Yeah. So you've taken a knot, you've locked it over here. Now this tension will not be carried forward.
Entire luminal compromise will not happen, and
Yes.
posterior and anterior parts are separated like this while you are suturing.
Yes. And now I would like to show is that as I've told, actually you can do it the other way also. Since this patient didn't have much of atherosclerosis, we did this in outside in of the external iliac artery. While many people would at this point of time have a view that why I have not done from inside out, but it can be done that way also. So before I take the other suture, I would make it sure whether all my lumens are fitted.
So, a good vascular surgeon sometimes argue that you should never come one step also outside in. You agree or
Yeah.
not that much importance? Half millimeter gap if you come exchange
Yeah,
and then
yeah.
come forward.
So
Suturing is
my
very.
take here would be you are anastomosing both arterial structure. So if there is as time are passing by, we are getting more and more elderly donors. In fact, you will find that the recipient artery is actually in a good condition and the donor artery is bad condition.
Oh,
So in that case, you should do this way so that you are more about the intima of the donor and not the intima of the recipient. So
okay.
this will so you can fix only one intima at a time.
You
Either
got
you
the.
fix the intima of recipient or a donor. But if you take both intima, if everything is done under vision, you take both intima, then it's not a problem. So into out works when you are doing it blindly.
Yeah. When you
So
are
you
open like this, when everything is seen, when
yeah,
the you know that needle is coming out quite from deep, so
yeah,
unlike the intima misses, and you will be fixing it anyway.
yeah. And if you are in a fix, then always take a suture slightly away from your anastomosis so that it fixes your intima. And in into side, it hardly matters if you take a large, slightly away from the anastomosis. As against in internal iliac artery, if you will take large chunks in internal iliac artery, it will pucker.
Yeah, yeah.
Again, I would not take the knot at the angle. So from above to mid and from below to mid. So this is my heel and this is my toe.
Yeah, yeah.
And now I would just tie the knot.
In the last part, ultimately you are making an anastomosis in the middle.
Yeah.
Uh, the suturing in the middle, coming few
Yes.
millimeters from above down.
Yes. So my knot is not at the cranial end, neither at the caudal end.
Foot end. Okay, accepted.
So as I have released the clamp, you can see there is no leak. Okay.
Yeah, yeah.
And the kidney is pink and turgid.
But
So if you
a small convention should I do? The amount of the widening and the approximation, all the technique in internal iliac artery is not here because
so
it's
you
a big
can
tube. It's a big tube. You have to see and carefully one millimeters. You have to
yes,
do it.
yes. If
Because
you
there technique is very important in there, where both have come like a everted edges towards each other.
so it is an experience that in external artery you can make arteriotomy as big as you can, and you can just keep on increasing spatulating of your donor artery. But if you keep on doing it for large amount of time, it will cause juxta-anastomal stenosis.
Okay, yeah. Okay, okay. Not at the anastomotic, just below the anastomosis on the
Donor side,
donor side. Okay, okay.
juxta-anastomosis. So if you want, I can just show
Show
another
it, show it,
visual.
show it, show it. I am interested, and this is a documentary, and again, it will not chance will not come.
So this why I'm showing is that this is a double vessel anastomosis. This we have done the internal iliac artery, which is done. So I'm not showing it again. This is the vein which is done. This is the internal iliac artery which is already done.
Okay,
So now this is the clamp which is on the external. This is again on external, and we are doing the second part of the anastomosis. This I am trying to show because this is the second smaller vessel, and how do you do external in the smaller vessel also. So initially we had thought and we had dissected inferior epigastric for that. So you can see this inferior epigastric
yes, yes.
is pulsating very well. But after we dissected this artery, we thought that this is quite big for an external inferior epigastric. So this should go in internal iliac artery, external iliac artery. So all the steps you can just revise arteriotomy, POTS, very well you can see.
Yes.
You can see it's
Yeah.
now again. So this time you will see a 2.8 mm punch going in. See the size of the punch?
Yeah.
Read it is 2.8 mm punch. So this video slightly has some interruptions in between, but you can very well make the steps in this.
Yeah.
Okay.
Yes, sir.
Now the point to be noted, what I want to show is that, see, your artery is long.
Yeah.
So you should not anastomose this way. So you should shorten your artery.
Okay. Because
So
it may
that, yes,
it may kink otherwise.
yeah, it may king. And sorry. So in this, I just wanted to revise the steps and show this point importantly.
Yeah.
Then this is again the steps from a different angle in a smaller vessel. So one, this is not holding anything. They are just retracting it. And this is, you are seeing it from a different angle. This is your arteriotomy. This is your,
Better, because otherwise it will not be seen.
yeah. So this is from an overhead camera.
Yeah. Normal camera.
No, not normal camera. The camera which is fitted in the light, booty light.
Oh.
So previous videos were from normal camera.
This is which light you told? OR light.
OR light has a camera.
And that means it is in the headlight or main light?
Main light. So now there are cameras available from GoPro. See, now as an assistant, somebody just inserts your forceps inside and you just come out. So this makes your life very simple. There is no holding of intima. You have taken a proper suture. So now you have some cameras available from GoPro company which can be attached to the head of the operating surgeon.
Yeah.
And whatever the surgeon sees, that camera captures.
Which company?
GoPro.
GoPro.
GoPro. I have yet to use that camera, but I have been told by this OT guy that it works well.
Yeah.
So now as we are approaching the angles, angles always take single one by one.
Better. Whenever you are in doubt, single bite.
Angles, it's always better you take single. So there will be no kinking. You can properly align, because the angles are very important. You have to align your artery that way. So as you were telling, this angle slightly away from the anastomosis, because it will fix the angle.
Fix the angle.
Yeah.
Fistula, I will do this. My favorite point this is. I am happy to do all the things because I do a lot of AV fistulas.
Okay.
Lot.
So transplant is a glorified AV fistula.
Yeah.
Glorified and responsible AV fistula.
Yeah.
Again, this out to in to out. Lock. You saw it?
And leave it.
Yes.
So that anastomosis is over there.
Yeah.
As if it is like that.
Yeah.
Now here again you are coming reverse bite.
Yeah. So we'll take 1-2 sutures more and then come from above. Because as I said, we'll tie the knot in between.
Yeah.
So if I stop at that point of time, the knot will come at the angle.
But that camera is handy cam or large Panasonic? Which one you have used?
For this video or the previous video?
Previous video. This video quality is less.
Yeah, this quality is less. That is just a handicap, Sony handicap.
Sony handycams have come very well now.
Yeah,
That quality is really superb.
yeah,
I am interrupting. Sorry, I hope you don't mind. Otherwise,
yes.
the topic becomes very dull and nobody will be attentive.
Uh,
I also know of it, so I am sorry for that.
yes. So again, at the last point, you come to know that the artery is very well distended.
Yeah.
You can continue your sutures. Again, you keep on doing it, and in the middle, tie the knot. So now the vein out. This is your second artery which is coming out.
Yeah.
This is your artery coming out. And this is your internal iliac artery. That
Yes.
will come out the last. So you see the pink kidney over here?
Yes. I will appreciate.
And there is no leak from any of the anastomosis.
Yeah, 3 are there. Nice.
Yeah. So if you spend time in doing a quality anastomosis, after declamping, your life would be like this.
Yeah.
No stress, simple life. See, this is a smaller vessel. It's not a main vessel.
Yeah.
And then this is the output, immediate output.
Very nice.
Now, if you, the last aspect of my talk is you have done internal iliac, external iliac. You have a smaller vessel of around mm or so. What do? It's a lower polar vessel. Even for inferior epigastric, if you dissect it properly, you can get a very good length of inferior epigastric. So one point of inferior epigastric is the dissection of inferior epigastric. So inferior epigastric should be dissected very well by your assistant or by yourself, so that there's no injury to the inferior epigastric and neither the vessel goes into a spasm, because it's a very small vessel.
Yeah.
This video is actually a small video, only one side of the vessel that I could get, but the principle are same.
Yeah.
There are two tubular structure. Suppose this is a lower polar vessel, this is an inferior epigastric. You spatulate it on one side, you spatulate it on the other side. This is a 7-0 proline. This is a 7-0 proline, finer forceps, pinpoint forceps, fine tip forceps, and what you can do is there are two ways of doing this. So if you have a friend of cardiothoracic surgeon, they have something known as T splint. So one edge of the T goes in one side of the artery, other goes in the other side, and the T part, it remains outside. So your anastomosis both the sides, and at the end just remove the T. So that
Yes,
will help you.
same like CBD anastomosis.
Yeah. And if you don't have this T, we can use just a 5-inch IFT. And this is a 7-0 proline that we are using, and I'll show you. So this is how it goes inside. So both your edges, it's almost like an internal iliac artery.
Yes, I got the point. Both are very thin, very small size actually.
Now this IFT has given just a splint. Otherwise, they would have wobbled.
Yes.
See, for me to not catch.
This I use in lab Boyari flap very much.
Yeah.
And while making the tube, very large, thick tube if you keep in Boyari,
Yeah.
You need not worry about the malrotation or disparity between the edges. In the last part, you remove.
And the other thing is that it gives me, so it allows me not to touch.
This is only one layer you are showing, other layer is already done.
Yeah, other layer is already done. It's like the internal iliac artery where one is done and you have just flipped off the anastomosis. Again, the same principle, equidistant, small edges, minimal handling, proper lay of the sutures.
You have little bad cough, so it's one of our talk.
Yeah,
It is
I saw
exhaustive
it.
actually. Talking 1.5 hours is not easy.
Yeah. Yeah, and I had
Your throat
I had
gets,
sore throat.
yeah, yeah. Take care.
Yeah.
In the last part, you have taken out the feeding tube now and suturing.
Yeah, now I'll be switching. Also, all
It is
finer
difficult
instruments are coming in.
because both are at the distal far ends. They are wobbling. It's
Yeah,
difficult to stabilize.
yeah.
It's
It's
not
a
fixed.
small vessel.
Both of them are not fixed.
Yeah. Whatever the size of vessel is, you have to still follow all the principle of vascular anastomosis. Sorry. So it's playing again. So this is the last suture which is coming in. You tie it off.
120 people are watching.
Yes, yes.
That but still 120 are watching.
Oh, that's nice.
That's nice.
Yeah. So now once you're done this, I'll show you the final picture once I release the clamps. So this was a double vessel again, and this is the so it has actually had a immediate pre-hilar branch. So this is an intra-iliac artery with these two branches of the artery. We could get a common stem. So that is an intra-iliac. Otherwise, it would have been a triple anastomosis. It's a common stem to an intra-iliac artery. This is the vein, and now I'll show you the inferior epigastric. You can very well see the inferior epigastric. Can you see the pulsation of inferior epigastric? Dr. Chandramohan, sir?
Hello? Yeah.
Hello, can you see it, sir?
Yeah, yeah. Now it has broken a little bit.
Okay, so I'll again go back. Okay, so now can you see the inferior epigastric?
Yes, yes, yes. I can see. I can see. I
See
can
the
see.
pulsations of it. So it's equidistant. So the width of this proximal distance should be the same. And this is the ureter going into the bladder.
Yeah, yeah.
Okay. Well, thank you, sir, for
Very
this
nice.
opportunity. And I just tried to share all the experiences and give all the tips and tricks to the younger generation, or obviously, uh, yeah.
Yeah, yeah. Thank you very much, Abhijit. And it is very nice illustrative video. I hope this will be very useful for everybody. There are hardly any questions for me because I have interrupted too much beyond my limits, so that it is interactive. And I could understand means everybody will understand. Properly understood the especially internal iliac artery anastomosis, that technique which you have shown. I did not know. We were doing it in different way. Only one bite and then not, and then do a rotation. Whereas you have taken two bites and then pulled, so that proper eversion and approximation has come. That is one thing. And very close recording of the vein, particularly without touching. As the first two bites you are adjusting the edge, and then after that you are continuously taking. I was initially afraid that the posterior layer may come or anterior layer may come, so you explained properly that what happens, especially thinner vein, the edge receding, so that it will never come, especially on the the graft side. And we used to take two prolin bites on either side, but it's 4 point suturing technique. And last inferior epigastric artery, I understood with basic principle, but I am feeling difficult to imagine to do it in the video, after seeing the video also, because they were too thin and they were stretched and they were long. All the three make the bite to take, unless the eyes of the surgeon only can tell exactly what has happened. So it's wonderful presentation. And I heard by many seniors that you are very sincere at transplant work. You are wanted to develop the transplant work. No wonder after 10 years you will be the making some for some regulations for the transplant, as well as some what do you say, guidelines for the transplant. I wish you all the best, and I wish you all the
Well,
best.
thank you, sir, for those kind words. And these are just the blessings of my gurus, Desai sir and Sabnis sir, which they have.
Great, great.
And I will just try to continue the legacy.
Yeah,
Well,
great.
thank you, sir, for this opportunity.
Excellent.
Thanks.